Okay, so good morning and welcome to PCEP for November 2024. Thanks for being here in person and the people that are here online. As we start every presentation, our focus from the Office of the MPD is to make sure that our slides advance, to provide consistent, high quality care when and where our patients need it most. And so today we're going to be focusing on airway, anaphylaxis, and toxicology with respect to that. Okay. Got it now. Okay. So the outline for today, we have a number of small updates that we'll go through. We're going to talk about the Airway Collaborative, which is a national project that we're participating in over the next year. Then we'll go into anaphylaxis and then go into toxicology. My goal is to wrap this in less than an hour. I welcome any questions as we go throughout. Okay, so a few brief updates. So with respect to protocol cadence, I put this in the last monthly update, but I'm just restating it now. So we're going to do our next major protocol update. We'll teach in January 2025 and go live in March 2025. After that, we're going to follow the cadence that they use in the metro area south of the river, where we teach in November and December. So we'll teach in November, December 2025, and then the next update will go live January of 2026. And then going forward, every January, we'll do updates. My goal in this is to provide more consistency, to bundle protocol updates together, and just to make it easier to keep track of. With that, we are getting ready to start recording online medical control calls. So there will be you'll see an update in your app when we update those numbers. The goal of recording the online medical control calls is for quality improvement. And that goes both ways. That is to improve what we provide on the EMS side, but it's also to improve the service that you're getting from the docs. I've done additional training for the docs on the rule for online medical control, but we're going to use these recorded calls as a chance to learn. It's not a chance to bust anyone. It's a chance to improve the way we communicate between people in the field and people who are taking those calls. The other thing that this new number allows us to do is that it can route the call to me or to Dr. Gadwa when we're available. So you are more often going to be getting an EMS doc who is taking the call. The key things are just when you call, leading with your name, your unit, and what it is you're requesting. I'm calling to ask for help with an AMA refusal. I am calling to talk about termination of efforts. Just be really clear in that first sentence what the reason for the call is, and that'll frame what the doc needs to do. Questions about that? Okay. So there is a national shortage of IV fluid. About 70% of the IV fluid in the US was made at a Baxter plant in Western North Carolina that was affected by Hurricane Helene. They were completely closed for 3 weeks. The goal, they're saying right now that they hope they can be up to about 80% of production by mid-December. So nationally, there's a shortage of IV fluid. There are no protocol changes in response to this, but I'm going to make a couple of recommendations so we can make the best use of the IV fluid that we have within the current protocol. So number one, if you're going to hang IV fluid, if you're ready to give IV fluid for an indication that's in protocol, almost always that's for shock. You're going to be for someone who is hypotensive. You're going to be giving fluid for that. We also, in protocol for hyperglycemia in patients that appear dehydrated, we have IV fluid in protocol for that. And think, it is completely understandable to, you have your rhythm, you start your line, you hook it up to a bag, and it's muscle memory. But because of this shortage, and thankfully the services that I've talked to, we're still in a pretty decent spot, but we don't want to get to the point where we have to really ration. So I think doing these simple things right now that should have minimal impact on patient care are things that we can do to conserve the fluid that we have. So unless you are going to give fluid for an indication in protocol, start a saline lock. The second one, just a reminder that in anaphylaxis and severe asthma, there are places in protocol where there's no option for IM epinephrine. Just remember that you have that option. If the person needs an epinephrine drip, start an epinephrine drip. That's a relatively small amount of fluid. It's a relatively infrequent use, but just remember you have both of those options. And then this is relatively rare, but we're not going to use IV fluid for things that aren't going IV. So if you need to irrigate something, in most cases you can either use, you can use tap water in the house, you can, or you have non-IV fluid that you can use for that. Any questions about conserving IV fluid? Mark, anything online? Okay. The next thing I just want to touch on, you probably all seen this as you're working. On October 15th, ESO turned on their longitudinal record. You can think of that, it's like a medical record number in the hospital where it links all of the different encounters that patient has with EMS. It is, at least as of right now and for the foreseeable future, it is just within your agency. So if the patient has only been contacted by AMR in the past, it won't necessarily show up in a CCFR record. But it is within your agency. If you've seen the patient before, you're going to see the previous visits. How does it do this? So it basically takes their patient matching software which they use for health outcomes, which we're working on, and it turns it back on the EMS record. So it based on name, age, spelling, date of birth, social security number, it finds likely matches. So the more accurate the information that goes in, the more likely you are to get a match. But if, say like, it's, you have a patient who's Scott with 1 T and then, his actual name is Scott with 2 T's, it'll recognize that and it'll take all the likelihood together and it'll tell you that there's a likely match. So if you put in 3 pieces of patient identifiers, then it will look for that. The most reliable way to get a match is to scan the patient's ID. I know not everyone has that capability right now, but whenever you can, if you can scan the patient's ID, that is the best way to get a reliable match. It also, in terms of getting how the patient identifies with respect to race and ethnicity, rather than having to assume or get from the patient, you're getting directly what they report to the DMV. So whenever possible, scan the driver's license. So what are you going to see when you do get a match? So you're going to see a list of the encounters that this patient has had before with your agency. And so you'll, as you go up here, you'll see, okay, we were here on this day, on this day, on this day. You're going to see monitor files that you uploaded. So if you're like, does this EKG look different from the EKG before? You're going to be able to see the EKG that your agency did before and compare. So it's a potentially really powerful tool. This is something that, I'm going to date myself, but like when I started my EMS career, paper only. When I started my hospital career, we were kind of in the mix between paper and electronic records. And now we're in this world where it's just electronic records. There's a study on hospital records. Each patient's record right now has about as many words in it as Moby Dick. So it can be kind of an overwhelming amount of information. So just a couple of tips on how to process this. Number one, as we mentioned, scan ID whenever possible. You're going to get the most accurate information and the best likelihood of getting a match. But then it is the previous encounters can really help you and can help you understand what's gone before. I know that I have burned myself in the past by saying like, oh man, the last time this person was here, it was psych. And this time it was psych. And this time it was alcohol intoxication. And this time it was methamphetamine intoxication. Just remember each encounter is a new encounter and bring a fresh brain to that because it is easy to have that past record kind of push you in a certain direction. Any questions about the longitudinal record? Okay. Okay, so we'll, that's all I have for updates. So we'll move on to the Airway Collaborative. So Clark County is one of 50 EMS systems nationwide that's participating in the National EMS Quality Alliance Airway Collaborative. And over the next year, this is going to be our bullseye in terms of quality improvement. We did a lot of work over the previous year on increasing the percentage of patients that are transported with lights and sirens. We've been successful in doing that. And so we made our community safer, our patients safer, without having negative outcomes as a result. And so the focus over this coming year is going to be on airway management. And we'll talk about the 3 key measures that, that go into this package. But there are small rural EMS systems that are part of this package, that are part of this group. DC Fire and EMS, Austin Travis County EMS, systems across the country are participating in this, and we're sharing best practices to learn about how we can do this best. So key measure, the central aspect is first pass success without hypotension or hypoxia. This is, and why do we care about this? Because our goal is not just to get a tube within the cords. Our goal is to continually deliver oxygen to the heart and the lungs. And so to do that, you need oxygen getting into the blood, and you need the blood pressure to circulate it. And so what I can tell you is right now, our self-reported first pass success for endotracheal tubes outside of cardiac arrest is 81%. And that's solid. And we've seen improvements as we brought video in. But now we're starting to measure the whole package. In other words, so it's for the 3 minutes before the intubation and the 5 minutes after the intubation. Was there any hypotension? Was there any hypoxia? Hypotension is defined as a systolic less than 90. Hypoxia is defined as a SpO2 less than 90. And we'll go into more detail, and we're going to bring some more tools to you to help support you in succeeding with this. And I'm going to want to get your ideas about how we can get better with this. But we know that if we resuscitate before we intubate, get the pressure up, get the oxygen up, it is much easier to have a successful intubation. I mentioned this in PCEP before, just my mind goes back to, there was a paramedic intern and I was working a shift in the emergency department, and I had this guy who had pneumonia and his oxygen saturations were like 86%. When he'd come into the emergency department, he was saturating like 70%. And the paramedic intern's like, can I do the intubation? And I'm like, I'm worried. I think this guy's going to drop really fast. Like, we need to have the most experienced person do this. I'm like, let's try to pre-oxygenate him. And so we did DSI, gave the person ketamine. We had him on non-invasive positive pressure ventilation. We got it sat consistently up to 95% for 3 minutes. And it took it from like, this is an intubation where I need to bring my A game and I need to do it as quickly as I can with all of my experience. You're like, no, the paramedic intern can do this. And paramedic intern struggled a little bit, but got the tube. And it's about creating the conditions for success. What I can tell you is the people who are going to be most important in making this work are the EMTs. I've said this before, but paramedics save lives, EMTs save paramedics. And I worked nights over the weekend. I had to respond to a code up on the floor. And it turns out the guy had a pulse. The RT was bagging this person. His head was purple, and the RT wasn't using an OPA. And I'm like, man, I know every EMT in the system can bag better than that RT. and that RT doesn't even know how to use a Halligan, can't drive an ambulance. Like, so the quality of the EMTs that we have in our system are going to be crucial to making this work. What else? There are two other measures in the package. So confirmation of an invasive airway with end-tidal CO2. So an invasive airway is defined as an endotracheal tube or an iGel. And when we think about like what are we doing here? What are we proving? Well, we're demonstrating the value of the care we provide to the citizens that we serve and the taxpayers who fund what we do. And so this is a quote that I think about a lot. Edward Deming was the father of quality improvement. And this is what he would say repeatedly: God we trust, all others bring data. Meaning we want to demonstrate the value of the care we're providing. So we're developing the measures for first pass success without hypertension or hypoxia. We can tell you today how we're doing with respect to confirmation of invasive airway. So goal is 100%. Anytime we're putting plastic down past someone's glottis, we want to prove that we have end-tidal CO2 on the end of that. And so our goal is to do that 100% of the time, where our median is around 97%. I just muted myself. Well, we're starting from a strong spot. If anyone's interested in going into detail on the measures, they're on the NEMSCA website. I'm just going to get back to my slides. Okay. And then the last measure in the Airway Collaborative is documenting that we provide oxygen to patients that have a SAT of less than 90%. And then when I first read that, I was like, isn't that pretty obvious? Like, don't we do pretty well with that? But it's not always. And typically when we don't meet this measure, it's either that the patient had a SAT that dropped down and it corrected without us needing to do anything. So if it was an erroneous measurement, it's okay to take that out of your chart. If it was a real measurement, you can just document, you can put in the flow chart oxygen, and then you can say not indicated because the patient improved without needing anything else. Okay. So with that, I want to think about those three measures, but especially the airway measure. I want to hear from the group and from the people online. What are your ideas to improve our success, especially first pass success without hypotension or hypoxia? And so I've got a live poll here. You can either go to this website or scan that QR code. It'll take a little bit of time. For the people that are watching this after the fact, we're going to leave this open. So I want to get your ideas as well. Leave that open for a little while, and then I'll show what we're saying. And is everyone, is that working for you guys? Is it you able to submit ideas there?
Yeah.
Okay, perfect. We'll get the, and I'll share what's coming up as we go through that. Okay. Any other questions about the Airway Collaborative before we move on to anaphylaxis? Okay. So with anaphylaxis, there are the official diagnostic criteria, and then there's a practical approach. I'm going to go through both. So the official diagnostic criteria for anaphylaxis are that you have sudden onset of an illness with involvement of the skin, mucosal tissues, hives, flushing, swollen lips. Okay, well, thank you. Is that showing up again? No, we're good. Okay, thank you. So you've got the hives, and then something else. You've got respiratory symptoms, drop in blood pressure. You can also see it with vomiting and diarrhea. So this is, yeah, I can work through this and I can think through this and like, do I have one of these? Do I have two of these? But I think for an approach in the moment, it's not the most practical. So I think this is a practical approach to taking care of anaphylaxis. If you've got something that looks like an allergic reaction, an airway or breathing or circulation is affected, then give epinephrine. So all of a sudden, someone got stung by a bee, you're seeing their airway start to swell. That's an indication for epinephrine. All of a sudden, someone, for some reason, breaks out in hives and they're wheezing. That's an indication for epinephrine. If someone has a peanut allergy, gets exposed to a peanut, and they start vomiting and their blood pressure drops, that's an indication to give epinephrine. And so I find that is in terms of my thought process, I'm looking at the patient in front of me and I'm trying to decide, do I give epi or not? If A, B, or C is involved, then do the epinephrine. And that's reflected in protocol. So if you have a mild reaction where no signs of anaphylaxis, you can give Benadryl. Benadryl will help with the itching, help with the other symptoms. Benadryl will not fix anaphylaxis. The only thing that will fix anaphylaxis where you have airway, breathing, or circulation affected is epinephrine. And so the other things that we do are adjuncts, but epinephrine is the key intervention. And I reviewed how this is something that we do well. This is something that we consistently and repeatedly do well. So you can start with IM epinephrine. And if you either already have an IV established or you have another reason not to, you can use an epinephrine infusion and titrate to response. Once you got the epinephrine on, then you can use these additional adjuncts. You can give solumedrol. Remember, that's not going to have much effect in the moment, but that's going to help prevent the rebound. That's going to really kick in about 2 hours. So by starting that in the field, you're helping the patient in the long term. And then if you have refractory shock, you're all the way up on your epinephrine drip, you're still shocking, then you can add in norepinephrine as well. For pediatric patients, same approach. Mild reaction, can give Benadryl, IV, IM, or PO. And then for a severe reaction, IM epi drip if needed, and then you can add in the adjunct. Any questions about that? Okay. One of the things to think about with biphasic reactions, so with anaphylaxis, most people had that initial reaction typically within that first hour of their exposure to the allergen. Some people get treated, even treated with IM epinephrine. They can get put on steroids, but there's a small number of people that'll have a biphasic reaction. It can happen up to 3 days after the initial exposure. It is rare. It is, and that is why we want to get a long-acting steroid. We'll either, in the emergency department, we'll either give them dexamethasone, which lasts for about 3 days, or we'll give them prednisone that they take every day. So by putting them on a steroid, we decrease the chance of a biphasic reaction. The things that put people at higher risk for a biphasic reaction, if they needed multiple doses of epinephrine in the first place, if they had a really severe reaction. Just keep this in mind. It is possible that you'll see someone in the field who is seen, treated for an allergic reaction, and they can have it come up again. And this is part of the reason that we want all these patients to go to the hospital so they can get that loading dose of steroids so they can be observed. What else looks like anaphylaxis? So ACE inhibitor angioedema can look a lot like anaphylaxis. The key clue there is that the patient is on some medicine that ends with pril. Those are blood pressure medicines like lisinopril, captopril. And it is weird because it can happen the first day that they take the medicine, or it can happen after they've been taking the medicine for 2 or 3 years. And they can just have this swelling. It typically involves the tongue, and get pretty swollen. It's typically a little bit slower than anaphylaxis, like over the course of several hours. So it's important to think about this and to consider any clues in the history that this might be what's going on. These are cases that if you think it might be anaphylaxis, it is reasonable to treat with epinephrine, but just note ACE inhibitor angioedema doesn't really respond to epinephrine. And these are patients that you need to have their airway managed. Preferentially, since they have a really swollen tongue and they're breathing on their own, in the emergency department, we preferentially will intubate these patients awake using fiber optics. So we never have to RSI them. That way you keep them breathing the whole time. You anesthetize their airway, plus or minus some ketamine, and basically typically like intubate them through the nose, put the tube in, drive the fiber optic scope down, and then you just see the cords, drive that down, but they're breathing the whole time. And so if you have a patient that you can get to the emergency department, let them know to set up for a tube. Preferentially, these are patients that we don't RSI because the risk is you RSI, take away their skeletal muscle tone, and then you just have this big tongue that falls back and blocks the airway. Hereditary angioedema can also present in a similar fashion. Also typically does not have the hives, and they just start swelling. Obviously the first time we never know. This can respond a little bit to epinephrine and to the other things. The key thing is to know with patients with hereditary angioedema, typically they know, or there's a family history, and they often will have a specific antidote that they may have either given themselves or the hospital will stock for them. Obviously, infection can also mimic angioedema, but typically it's a more gradual course, typically over several days, typically some fever, typically some other signs involved. And so consider that. The other thing that I've seen mimic angioedema, pretty rare, but subcutaneous emphysema. So I remember taking care of a patient who she'd had a lung surgery, she'd been on a flight, and then came down, and then things just started swelling, and like she looked really swollen, really popped up here. But you touch on it, and it's like touching like Rice Krispies. It just like crinkles and stuff like that. So it's pretty rare, but subcutaneous emphysema can also mimic anaphylaxis. So key points about anaphylaxis. Epinephrine is the first line treatment for anaphylaxis. If airway, breathing, or circulation are affected, give epinephrine, and then everything else is an adjunct. Any questions about anaphylaxis? And anything online? Okay. Okay, so now we're going to dive into toxicology and try to bring out some of the key things to think about. So general approach to a patient with toxicologic emergency. Think about securing the scene. And so with, what if, many toxicology things that we go to, our patient swallowed a pill, you're not worried about that. But there are cases where whatever is making the patient sick has the potential to make you sick as well. Get the key history, understand what the toxin is, get your physical exam, and then treat. Antidotes, decontamination, if indicated, antidotes for a handful of poisons, and then everything else is supportive care. So what are some cases where whatever is making the patient sick could make you sick as well? Pesticides, yeah. So in our area, so organophosphates, especially, are something that we definitely see in farm workers. We can get exposure to that. In terms of decontamination, they tend to be really persistent. And so those are things where it's really important to get the decontamination done before you dive into treatment. If you had to guess, what would you guess is going on in this top picture? Yeah, that's that. So obviously there are plenty of hazards that you need to think about there. And then I think about also one thing that we do see with fentanyl is that it is a lot rarer for people to be using IV drugs. I started here in 2013 and worked mostly nights. I used to drain one shooter's abscess every night that I would work because people were injecting heroin. People are a lot more likely to smoke fentanyl or to ingest it. So we are seeing less IV stuff. But if you are having to wake up someone with Narcan, just think about the sharp things on their body that could potentially injure you. Okay. We're going to talk through the key toxidromes. So you get the history, you see what's going on, and you're trying to put a picture together. Does the patient have any of the toxidromes that you need to recognize and or treat? So an anticholinergic toxidrome. What are some medications that can cause an anticholinergic toxidrome? What we talked about, what are other, yeah, pesticides. But Benadryl also is anticholinergic. And in general, like anti-nausea medicines, like dihydramine, that's meclizine, things that are used to treat nausea, motion sickness, those are typically cholinergics. So they're going to tend to increase your heart rate and your blood pressure. Not much difference with respect to respirations. They will tend to be hot. Their pupils will tend to be dilated. I know we're not listening to bowel sounds a lot, but they typically won't have bowel tones, and they will be dry. This is the hot as a hair, dry as a bone, mad as a hatter. So the cholinergic those are your organophosphates where they're just drowning in secretions. Pupils will tend to be pinpoint, and it's less that there's a major effect on vital signs. They're vomiting, they're pooping, they're sweaty. These are nerve agents, and so those are So what's the antidote for that? Yeah, sledge is the mnemonic for the toxin, and then atropine is the antidote for that. So opioid, this is something that we're all familiar with and see regularly. So you typically see decreased heart rate, very decreased respirations. If they've been down for a while, they tend to be cold, pinpoint pupils, be a little dry. Sympathomimetic. What's the most common sympathomimetic that we see our patients on? Yeah, methamphetamine. So heart rate is up, respiratory rate is up. They tend to be hot, dilated pupils. They can be pretty sweaty as well. And then sedatives and hypnotics. Those are medications like benzodiazepines. Think about that as essentially coma typically with normal vital signs. The heart rate may be down a little bit, the respiratory rate may be down a little bit, but the biggest thing is just their mental status is just not there. So the key pieces of the history are to get the timing as best you can, and then as many details as you can get about the medications, whether that's taking pictures of them or bringing the bottles. It matters a lot in terms of the planning. Is it an extended release formulation? How many milligrams? Any information that we can get about what exactly the exposure was can be really helpful in the treatment. Okay. So for things that are inhaled and absorbed, you're going to get the decontamination done first. So think about, someone who is exposed to pesticide, copious irrigation before you move on with other treatment. So GI decontamination, and the most common question that I get, I'm taking care of a patient, like say a 16-year-old who overdosed, parents will say, aren't you going to pump their stomach? So GI decontamination is rarely used. It is only used for life-threatening substances where there's no antidote, and then typically then it's only used in the first hour after the ingestion. So pre-hospital, we have the option of activated charcoal, which you can give after discussing with online medical control or poison control. The reason that we're cautious with activated charcoal is just that if the patient's airway is going down, having someone with activated charcoal in their belly can be a real mess. And the worst case outcome in activated charcoal is like you get any of that into the lungs. That's causes a lot of long-term lung problems. So if we're using activated charcoal, it's because there's something that's dangerous. There's not a good antidote. We're getting it early enough, and we think that they can protect their airway. So in the hospital, in some cases, we'll do whole bowel irrigation. For example, a kid that took a bunch of iron tablets, basically we do like a colonoscopy prep and just make them like poop until everything's clear. And that's pretty rare. And then gastric lavage, putting something down, pumping the stomach, you're going to intubate them and pull stuff out. I have done that. I guess I graduated from medical school in 2008. I've done that once. So it's just a very, very rare thing to do. Okay. Because one, most things have antidotes, and two, it's pretty rare that you're catching it in that first hour after. So with respect to antidotes, so sympathomimetic, cocaine, methamphetamines, midazolam is what we have for that. And so if someone's agitated, toxic, and they've got the sympathomimetic toxidrome, midazolam is what's going to be the most helpful for patients like that. Obviously, we give naloxone for opioids and for the acute overdose. For cholinergic toxidrome, we talked about atropine in terms of field treatment, and then the hazmat team also has TUPAM primarily for self-rescue. Cardiotoxic drugs, beta blockers, anything that ends with OLOL, calcium channel blockers, calcium gluconate one time can help to drive some of the messengers inside the cell. It can help to reverse some of the effects of that. But those cardiotoxic drugs are among the most dangerous drugs because there's relatively little that we can do for them. For anticholinergic toxidrome, so Benadryl is the most common one that we see. There are some substances found in nature like Jimson weed that can give people an anticholinergic toxidrome. Rarely we will give physostigmine in the emergency department. That basically is a cholinergic agent. But you have to have like really, really careful monitoring, and it typically just will reverse them for a little bit, and it kind of lets you know what's going on. It's pretty rare to give someone multiple doses of physostigmine. Sodium channel blockade. So this is why Benadryl is such a messy overdose, because it both has the anticholinergic effects and it's also a sodium channel blocker. So what do you see on the EKG if someone's sodium channel is being blocked? Yeah, wide rhythm, wide QRS. So that's your cue that there's a sodium channel blockade. Tricyclic overdose, tricyclic antidepressants. They, were the first generation of antidepressants. Those are drugs that end in tryptyline, nortriptyline, amitriptyline. They kind of, as the newer antidepressants came in, they were prescribed a lot less. Now they are being prescribed less for depression, more often for migraine and for other things, but they are particularly dangerous in overdose. So the treatment for that is sodium bicarbonate, and you may need multiple doses. You're trying to get the QRS back to now. And then for cyanide, we have sodium thiosulfate. Any questions about antidotes? Okay. In terms of supportive care, we manage the airway, particularly in aspirin overdose or other things that give you this metabolic acidosis. As much as possible, we want to avoid intubation because it's really hard. These patients will be breathing really fast to try to counteract what the aspirin is doing in their system. It is really hard to keep up with their respiratory rate. If you do need to intubate someone in an aspirin overdose, you're going to set their respiratory rate to whatever it was before you intubated them. Treat the nausea to help the patient protect their airway. Give oxygen as needed. And tidal CO2 can be helpful, especially for things that depress respirations. Consider a fluid bolus if the patient is hypotensive. Keep on cardiac monitoring. And then remember that many of these drugs, especially sympathomimetic anticholinergic drugs, can cause seizures. And so just be ready to manage a seizure. We'll talk, there are a handful of drugs that are pretty dangerous. And in pediatrics, you can think of them as the one pill can kill drugs. And so it's a key thing to get in the history. In general, these are drugs that are relatively dangerous in adults. And so they're dangerous because they either have significant cardiac, metabolic, or respiratory effects. It's a relatively small list, but I think it's worth touching on. So we think of the most dangerous overdoses. So mentioned already cardiac drugs. So beta blockers, anything that ends with OLOL, decreases heart rate, decreases blood pressure. They tend to cause hypoglycemia. And so you want to keep an eye on the sugar in a beta blocker overdose as well. Calcium channel blocker overdoses also decrease heart rate, also decrease blood pressure. Unfortunately, there's no one ending or name that makes them easy, but in general, the blood pressure medicines are medicines for heart rate. Verapamil, diltiazem, and amlodipine are by far the most common ones. They will tend to make you hyperglycemic, but for both of those, the EMS care is the same. Alpha-2 blockers can be dangerous in overdose. So the most common one we see is clonidine. Some people are prescribed that for blood pressure. Some people are also prescribed it for psychiatric indications. Guanfacine is something that we see more of. It's especially used in mental health for pediatrics. That's an alpha-2 blocker. And then tizanidine is a muscle relaxant. You'll occasionally see someone who has musculoskeletal low back pain who gets prescribed that. But those are also pretty toxic in pretty small doses. They will tend to have a presentation that looks a lot like an overdose, and they might even respond a little bit to naloxone. We talked about tricyclic depressants. Amitriptyline and nortriptyline are the most common. So they increase the heart rate, widen the QRS, drop the blood pressure, drop the level of consciousness. They look anticholinergic, and the pattern the tricyclics follow is they get really tachycardic, and then they seize, and then they die. So we use sodium bicarbonate, and if needed, give repeated doses, trying to get the QRS back to less than 0.12, and then we give midazolam for seizures. Antimalarial drugs, and hydroxychloroquine is the one that we probably see the most often. They're also used for rheumatic diseases, So people with bad RA might be on hydroxychloroquine. Plaquenil is the brand name for that. And some of these were briefly thought to be helpful for COVID and then proved not to be helpful. And so those tend to decrease blood pressure, decrease the QRS. They're going to look somewhat similar to these other QRS widening medications like Benadryl. And so if you're seeing the QRS get wide in a toxic overdose, it's reasonable to give bicarbonate. Be ready to give midazolam for seizures. And then the last one, the class 1 antiarrhythmics or the local anesthetics. For cardiac drugs, flecainide is the one that we see most commonly. That's someone who like, for AFib, it'll be given as like a pill in the pocket drug. They go into AFib, they're supposed to take a dose of flecainide. Not dangerous when an adult takes it, but if a kid gets a hold of a pill of that can cause significant toxicity. The other drug in that class, benzonatate, which is Tessalon pearls, which is a cough medicine. And so those can also cause that QRS widening. So the key, if I had to summarize everything on this side, I would say be worried about beta blockers and calcium channel blockers. They make people super sick. For other things, if the QRS is wide, give sodium bicarbonate. If it looks like an opioid overdose, give naloxone. Any questions about that? Okay. Dangerous drugs because of their metabolic effect. So diabetes drugs, in general, the ones that start with G can just really drop glucose, and you can get, kid can get one pill of that, and it can bottom out their glucose. So if kid takes one of grandma's glipizide, that's 24-hour monitoring because those are long-acting medicines. They'll bottom out the sugar. Toxic alcohols, rubbing alcohol, antifreeze. In kids, a relatively small amount can be toxic. So just think about the in kids. Antifreeze is now given this taste, and the reason for that, the coloring, that kind of fluorescent coloring of the antifreeze, is just to make it really easy to see if someone's ingested some. But just can consider that as you're getting the history, and then salicylates like aspirin. Relatively small amount of aspirin can make kids sick. They'll tend to have increased respiratory rate, increased heart rate. They can talk about a ringing in their ears. And that's respiratory effects. It's primarily the opioids. The ones that we really worry about when kids get a hold of them. So fentanyl patches are a particularly sneaky one because they'll be, so this fentanyl patch is 75 micrograms per hour, and that patch is meant to be worn for 3 days. So it's, I'm not great at math, but 75, you can think about how much fentanyl it is. 75 micrograms of fentanyl an hour for 3 days. There's tons of fentanyl in one of those patches. So if a kid gets into that, that's going to be a really prolonged period of monitoring. And then the extended release opioids like OxyContin, those also just have a lot of drug and can have an effect for a long time. And then the last one I want to mention with the dangerous ones, this isn't a one pill can kill, but this is something that multiple pills can make kids really sick. I had a patient die a couple of years ago. He's an iron ingestion. Can be particularly dangerous for a kid, and they typically will be, they can be in gummies, they can be in these things that look like candy to kids, and so a toddler can get into these. But a significant iron ingestion, you probably need to get 20 or 30 of these, but that's definitely within, show me a toddler that can't eat 20 or 30 gummies. So those are potentially dangerous, and just one other thing to think about as you're gathering the history. I don't expect anyone to remember all of this, but the key thing is don't hesitate to involve poison control, and just think about which things are potentially dangerous and could potentially need you to intervene. So bringing everything back together that we've talked about so far today, with respect to the Airway Collaborative, if we're using an endotracheal tube, we want to get first pass success without hypoxia or hypotension. The key part of that is resuscitating before you intubate. Remember that our protocol for DSI means that unless you can get the oxygen saturation to 94% for greater than 3 minutes, you should just manage that patient with a supraclonic airway. In anaphylaxis, if airway, breathing, or circulation are affected, give epinephrine. Know the EMS antidotes for key toxins. Don't hesitate to involve poison control if you have questions. And then just be aware of the handful of drugs that are particularly dangerous in overdose. And I'll take any questions. That's what I have, but I really value your feedback. The key pieces of feedback that I've gotten so far this year on this are, one, this needs to be relevant to EMTs. And so I want your feedback on how I'm doing with respect to that. And two, that people do better when this is an hour or less. So we're at 51 minutes. And but let me know. I definitely want your feedback. I want to make this the highest quality education that we can. Okay. And I'll post this in the chat.